It's a great privilege for us to begin with our first speaker, Dr. David Kuhl. Dr. Kuhl is a professor of medicine from the University of British Columbia, where he completed his family practice training and practice as a family physician. But the bulk of his research and education program development has been around sustaining healthcare professionals in the workplace, understanding the effect of being in the presence of suffering, and working with healthcare providers in addressing resilience. So again, it's our pleasure to have Dr. Kuhl speak to us this afternoon about communication and resilience in end-of-life donation discussions.
Thank you very much. Good afternoon. It's a great honor for me to be with you today, and I'm just going to put my work history into a bit of a larger context. In the 1980s, I was involved in starting the palliative care program at St. Paul's Hospital, one of the first hospitals in the country to provide care for persons with AIDS as well as those with cancer. And it was that experience that then resulted in my doing a PhD looking at the psychological issues of experiencing a terminal illness. And my clinical work at that time had to do with soldiers in transition from military to civilian life. All of that will make more sense when I talk about vicarious trauma, because they're related to PTSD, which was also part of my training. These are my objectives for today. Peter Brindley yesterday ended his session by saying, "No task before relationship." That, in essence, covers my entire talk. Because in the work that I do and have done for the last decade, it has been with healthcare providers, it has been with the quality of task, but more importantly, with the essence of relationship and how that affects task. Healthcare is about curing and healing, art and science. It's all of these things. It's based on a business model of efficiency. However, the work we do is about relationship, our sense of self, our relationship with others, and our relationship with something bigger than ourselves. And in the midst of all of that, we have tremendous challenges that we meet every day, and the challenges that change every day. And if you look at the bottom one, it has to do with the notion that each healthcare provider is a limited resource. That's you, that's me. So while much of the conference has been focused on donors and what you are doing clinically, this talk will be primarily about you, in the context of your work and in the context of the teams that you work on. In the 1920s, Francis Peabody said the secret of the care of the patient is in caring for the patient. We learned another secret, that in care of the patient is in caring for the healthcare provider. So that was the reason why Carl Roy, the then CEO of Providence Healthcare, created the Center for Practitioner Renewal, because he felt that because they were the largest faith-based organization in the country, it behooved them to begin to look at what do healthcare providers need in the workplace to do their work well. And he asked if we would be interested in providing something psychological for teams and for individuals. I was particularly interested in taking that position, not because of the request, but because of my own experience that I had when I was doing my research with people at the end of life. My dissertation question was, what's it like to know you're dying? And one of the most startling themes that emerged from the existential phenomenological approach had to do with iatrogenic suffering. A 79-year-old woman had been assured that the mass in her groin was benign, both by her family physician and the surgeon. She insisted that they excise it. Eventually, they complied. And from the door of the anesthetic, from the recovery room, the surgeon said to her, "Oh, by the way, we were wrong. It's cancer. I've made an appointment for you to see the oncologist in a few days." She defined iatrogenic suffering. The way the doctor talked to me caused me more pain than the pain from the disease itself. I wish she'd been the only one of the 21 people who participated in that study to have had that experience. Another one said to me, after the way I was told how I had HIV and AIDS, I tried to kill myself. And a young man in his early 20s said the way the doctor and nurse talked to me made the Lionsgate Bridge a viable option. So what I decided is that I wanted to explore how is it that we as healthcare providers actually contribute to suffering rather than eliminating it, rather than diminishing it. And my sense is we do it unintentionally. My purpose began to be, how can we work with people so that the end-of-life experience for them and for their families is not one that is added suffering, but the process of healing. How can we usher people through the end of their lives such that they don't have any regrets as they near the end of their lives, and that their families don't have any regrets because they missed something. They missed an opportunity for an important conversation. They missed the opportunity to make a decision in terms of organ donation. How can we begin to relate to people and interact with them in such a way that it's actually a positive and a constructive experience? Iatrogenic from the healer suffering. And in that context also, to begin to look at what is resilience. When I've got all of these demands on who I am in the midst of the challenges that exist, am I able to bounce back? How does my work affect me? In that sense, we need to ask questions such as, who am I, who are you, and who are we? Because how we work together can affect how we feel about our work, the meaning we have in our work, and it can certainly affect the outcome. We're familiar perhaps with the definition of patient-centered care. It's our purpose. It's why we go to work, is to focus on patients and what do they want, and can we begin to address their needs. The process has to do with relationship-centered care. Our sense of self, again, our relationship to the patients, a relationship among team members, and then also the bigger healthcare system. Because if we can optimize all of those relationships, we'll be more assured of high-quality care, high-quality work environment, and superior organizational performance. So what is it about relationship-centered care? It means we begin to appreciate the perspectives, the skills, and the features that other people can bring to the workplace. It means we can begin to understand how we do things differently, but we may have the same goals and the same outcomes. Based on these 4 principles. Who do I bring to work? Is it just my mind, just my thought, just my skill? Or do I have the capacity to bring my whole self to work? My feelings, my emotions, my sense of self, that all of who I am is embedded in the care that I provide. And the essence of every relationship, whether it's professional or personal, has to do with communication. Communication is the cornerstone of that relationship. And we know from the literature that sometimes we miss opportunities in terms of that communication, and it has an impact. We also know that from the study that was done by Tamblyn, where she followed doctors in terms of their licensing exams and the questions that they'd asked on that exam with regard to relationship. And the doctors that did poorly, that scored poorly on those exams, were followed over a period of time. And she investigated and learned that in terms of their communication skills, patient satisfaction was diminished. There were higher rates of complaints, as you see on the slides. There's the clinician-clinician relationship. I am going to talk briefly about some of the other features that we experience in the workplace. But when we first started the Center for Practitioner Renewal, we thought it would be all about moral distress, vicarious trauma, compassion fatigue. But what we learned very quickly, that our work was all about relationship in the workplace. The way we treat each other has a tremendous effect on our sense of well-being, and it has an effect on our resilience. And we're influenced by the organizations with which we work. If you look at business research, you'll hear that an organization is only as effective as the core values, as the soul of its leader. And how are the values of that person translated throughout the organization? Very important questions. And in the complexity of all of this, we have the ethical obligation to be beneficent and non-maleficent, to do good and do no harm. And often we think of that only in the context of our relationship with patients, but it's much bigger than that. And when I look at donation and the process of donation in this country, it has a tremendous number of stakeholders, so that all of what you see on this slide is involved in the work that you do every day. And we have, again, the capacity in that context to do good and hopefully diminish or minimize harm and hopefully do no harm at all, so that anybody in any direction can affect the relationship and the impact they have on the process on any other component. And it begins with our sense of a relationship with ourselves. Do I know myself? What's my sense of my self-awareness? What's the depth of my self-knowledge? And how do I bring that? How does it affect in my work with my colleagues? How does that affect my work with donor families? Ultimately, the question then is, who am I? And interestingly, the research I did asking people what it was like to know they were dying, 2 questions emerge. First one, who am I? Second one, what do I really want? So ultimately, it's an existential question. And in the context of our work, what did I hear from people? I heard about burnout. Just don't have the energy anymore. I've lost my ideals. There's moral distress. I believe the origin of moral distress is first described in ICUs and emergency departments. It often has to do with the relationship between the nurse and the physician. The physician writes the order, and the nurse feels that it's not in the best interest of the patient. But because of a relationship that's gone sideways previously, doesn't know how to tell the physician that he or she disagrees with them. And you know, that reservoir of discontent, that reservoir of animosity, can last for a long, long time. I remember working with one team. We walked into the room and we could hardly begin our work because the animosity within that team was so great they could hardly talk to each other. We've worked with teams that have carried that animosity for 10 years. The last time I called that doctor on call, he swore at me, asked what the hell am I doing calling him at 2 o'clock in the morning. I don't want to call him anymore. Those are remembered for indefinite periods of time. And what I learned in terms of being a palliative care doctor, I was Dr. Everybody. I was all the doctors that person had experienced until they came to the end of their lives. So I heard and experienced what they had experienced in terms of their process of going through healthcare. And then from the writing of Judith Herman, what she would say in terms of psychological trauma is that any of us are at risk of being psychologically traumatized if we have a sense of helplessness in the face of unfixable suffering. If you've been in healthcare, if you've been in your work, it's probably a day or two before you're exposed to perhaps that unfixable suffering. And then there's the notion of grief. Grief is wanting more of what we will never get again. And grief doesn't just belong to death. Grief also belongs to change. Healthcare is full of change. You can be working with a team for 5 years, and one day some administrator decides that the head of that team needs to work someplace else, so they get transferred. And we just go on as though nothing happened, but it's a different team the next day. And what do we do to process that? So often what we did in our work at the hospital, if teams changed, we try to have some way of saying, today this team ends. On Monday morning when somebody new is on your team, it's a new team. And we need to begin to acknowledge that because all of that affects who we are. And what you can see from this is that grief is a very complex emotion. It has all of those components on it, the most challenging of which is isolation, a very normal response to grief. Because when we're in grief, we withdraw. And when other people are in grief, we try to avoid them because people are generally uncomfortable with grief and loss. So what do we do with all of that? And that grief could be part of our work. And I've spent 2 years working with the BC Transplant Group. I wasn't aware that unless there's grief and trauma, those people don't have a job. And it took me a while to appreciate that. And so when they told us that when they hear motor vehicle accident reports on the radio, they begin to appreciate that that's their work. Now, when I hear those reports, I realize that's somebody's work. So the fact that somebody is stepping into grief and trauma every day of their job, and if we believe that every relationship we're in is reciprocal, it works both ways. I have an impact on you, you have an impact on me. It can't be any other way. So I need to begin to explore and look at what might those components be. Because that, in order to deal with this, in order to deal with this gently, in order to deal with this in a way that this family won't have any regrets, but not just not have any regrets, but perhaps I can contribute to the healing process that every family deserves or needs to go through. Because you know what I learned is that if things go sideways at the end of life, apart in terms of my palliative care experience, if the doctors or the nurses treat the patient badly, the surviving family have to grieve the process of the awkwardness and the ugliness of that event before they can grieve the loss of the person they love. I've been out of palliative care for 10 years, and about 2 years ago, I got a letter from somebody saying, surely this shouldn't have happened because the doctor treated my boyfriend so badly. Cannot get into their grief because they're so upset with how the expectation that somebody would treat them with compassion and empathy actually treated them poorly. It lingers. It lingers for long periods of time. And then there is the notion of vicarious trauma, secondary trauma, and compassion fatigue. Those used to be almost used interchangeably. Now they're beginning to do very, very specific research to try to differentiate what those definitions might be. If in your job you invite the story of another person into your life that includes trauma, abuse, hurt, you're at risk of vicarious trauma. Study was done with psychologists who didn't have histories of abuse or trauma in their lives, but in becoming therapists to those who had been traumatized, they began to take on the same features. And that's why my work with the military in their transition from military to civilian life was so relevant to my work in healthcare. Because I was working with people who'd experienced PTSD, and now I was working with people who manifested features of PTSD, but it was not necessarily through the trauma, but more so through vicarious trauma or secondary trauma. And what are the signs of not just the vicarious trauma? What are the signs of moral distress? What are the signs of grief? What are the signs of vicarious trauma, compassion fatigue? They're all of these things, most common signs. Ask yourself the question, are you more cynical now than you used to be? What's your sense of exhaustion? What's your sense of depression? Because in the stories of the people that we worked with, and in the course of the 10 years that I was at the center, we worked with over 75 teams and hundreds of individuals, and these are what we heard in our stories that they told us. And you know, something that actually became humorous from where we sat is, beware of the team that wins the award for being the best team. Because definitely, 6 months later, one member of that team would come and seek help because the team wasn't all that it had pretended to be. So we've heard the stories. And in the sense of the stories, we also have seen, witnessed, and heard that people are hurting. Healthcare providers are hurting. Because remember what I said, the moral distress, vicarious trauma, all of those things are present. And they affect how we relate to each other. But the greatest concern that people expressed in coming to see us, either as individuals or as team members, was the hurt that existed in their teams, the way they didn't feel respected. And so how is hurt manifested? Before I tell you that, remember, hurt people hurt people. If I don't transform it, I transmit it. If I don't begin to process something within myself, because you hurt me and now I'm angry. We rarely admit hurt. We often can express that in anger. This is what we heard and this is what we saw. Bullying, uncivil behavior, working together for 5 years and not being known by name. Bullying's easy, and now people have, bullying policies. I'm generally not a bully, but I can be uncivil. So what we would do when we worked with teams, we'd get a big piece of paper or a whiteboard, write civil on one end and uncivil on the other. Go for it. Tell us what your experience is on your team. How is it that I'm uncivil? Because I'm the head of a team. My supervisor told me something that would make their jobs a lot easier. I'm just too busy to talk to them. I tell them 4 months later. That's uncivil. They don't feel respect. You've known this for 4 months and you didn't tell us? It's not intentionally uncivil. And as their leader, I cannot tell them, or I cannot say that I'm uncivil. They have to tell me. Another important nugget, if you're a leader, is one of the most important features of job satisfaction is a positive relationship with your leader. If you're the leader, you can't answer that question. The people that work for you have to tell you, because they've done studies. We could do a survey of a team, and they would name all of the awkwardness, all the things they didn't like about the leader. If then you bring the leader into the group and say to them, the leader starts talking, and you start asking them, they would change their minds. Because there's a power differential. So it's really important for leaders to understand that to really know your team, the team has to feel safe and secure enough to talk about how the team is functioning, what works, what doesn't work, and what's missing. Because in all of those features, what are the impaired domains? The first two are the most important. Why do I say that? Because in terms of effectiveness as a team, the most important ingredient is cohesion. And the most valuable contribution I can make as an individual on that team is being congruent. So my inside world and my outside world are the same. If I'm annoyed or I'm pissed off at you, I don't smile and ask you how you're doing. I say, can I have a conversation with you? I need to talk to you. The way I treated you the other day probably was what may have hurt you, and the way you talked to me the other day, I also felt hurt. So can I be congruent with who I am? Because then I can contribute to the cohesion of the team. And cohesion is experienced and manifested through safety, inclusion, and trust. That phone call, because somebody was told, "What the hell are you doing calling me at 2 o'clock in the morning?" That person didn't feel safe anymore. So how do you reintroduce? How do you create some safety? And the person might generalize it. I don't generally call doctors. I try not to call doctors anymore at 2 o'clock. And a team can work in your best interest. I remember getting a call at 2 o'clock in the morning from a nurse on the palliative care unit. And after she told me the scenario and asked me what I was going to do, I gave the order. And she said, "David, are you awake?" I said, "Of course I'm awake. I'm talking to you." She said, "Well, let's just stop here for a minute. I've never heard you give an order like that for this situation in my life before, and we've worked together a long time. Are you awake?" So I said, "Give me a second." So I said, "Start from the top." We went through it again. I gave a different answer. What happens if that nurse is annoyed with me? She takes the first order. I just wrote down what he told me to. Trust, it has to work both ways. What is a team? A small number of people that have goals, objectives, and they work together to make them happen. And perhaps we need to look and explore new ways of being together, because healthcare is changing. How we function in teams is changing. Just because I'm the doctor, does that mean I should chair the committee? I should be the head of the team. How do we begin to negotiate that? How do we begin to understand how we can best function and work collaboratively? Ask these questions in terms of your team. Do you have clear objectives? Do you work together to achieve them? And do you meet regularly? Often when we get asked to do a team consult, we'll say, "How often do you meet?" Never. You never meet? You're not a team. You're a lot of adults working together to perhaps provide care, but you're not a team. And it's better to declare that than to pretend that you are a team. So we've adapted models from the business world in terms of how can we begin to look at healthcare teams. And the most essential ingredient, again, is trust. And the next piece is really challenging, is am I able to express a difference of opinion that could result in conflict? Many healthcare, and there's evidence in the literature, many healthcare providers have an aversion to conflict. So we like to be nice, but we don't want to say anything that would result in conflict. That really impedes our ability to function well as a team. So how do those lead? They lead to dysfunction. So absence of trust is an indication that people are shy to be vulnerable. Because on a team, I have to be able to tell you what I think my strengths are, what your strengths are, what my weaknesses are, and perhaps what yours are. I need to be able to acknowledge that you're more skilled in some areas than I am. And I need to be able to address conflict and differences respectfully, because if I don't, we just maintain an artificial harmony. And one of the biggest challenges, especially in academic centers, has to do with the top one about results. Because in academia, in order to get promoted, you have to be special. You have to have important skills. You have to have skills that make you unique from other people. So that can sometimes be a conflict with regard to how we function as teams and how we work together. And we use other models from psychology and social work to understand who are we in the context of the work we do. So this is an excellent model in terms of what we see in each other is the behavior, is the top of the iceberg. And one of the features that really can interfere with our ability to function well has to do with feelings and feelings about feelings. What I learned well in working with the military is that the philosophy of the military is stoicism. What's interesting is that healthcare, medicine is fashioned after the military. So we too are often stoic. If you have an emotion that impedes your ability to function in the workplace, get rid of it or leave. If it's too hot in the kitchen, get out. Well, that makes sense. In the military, excuse me, in the middle of a fire, I don't agree. It's not a good place to disagree. What part of ourselves can we begin to contribute in terms of the emotion? So if we feel sad, what are our feelings? Do we feel embarrassed about the sad? So the feelings we have about our feelings are very significant. And the other thing that's particularly significant about this slide has to do with the expectations. Unexpressed unexpressed expectations are detrimental to intimate relationships, whether they're personal or professional. And we get into a lot of trouble with unexpressed, unvoiced expectations. What do you expect of me? What do I expect of you? What do I expect that you expect of me? And how do we begin to have those conversations? How do we do that safely? And we need to create parameters and places where people can speak honestly and truthfully about who they are and where they want to go in their careers. This is a very significant slide in terms of intention cannot determine effect. Of course, she didn't feel heard. She knows that my intention would be never to hurt her, but I can't unless I ask the person what effect I had on them. I won't know. I won't know that I hurt their feelings, that I annoyed them, and they won't know my intention unless I make them very clear. We need to borrow from people like Carl Rogers, who taught us about expressed empathy. Empathy isn't just an emotion, because sometimes our emotions may be very different than how we express them. So it's important for us to be able to work hard to understand the experience, the behaviors, and feelings of another, and not necessarily use ourselves as a reference point. So the key points are that we understand empathy doesn't just belong to patients and their families, it belongs to our colleagues as well. Basic human need to be seen, to be heard, and to be understood. And if we can bring that to the workplace would change. We teach people skills about communication, whether it's talking about code status, whether it's talking about difficult or challenging diagnoses, but we've also used those same skills to get people to talk to each other about the awkwardness of collaboration, the awkwardness of work, the hurt feelings, the annoyances, so that people are developing new skills in terms of functioning together as teammates. We work with teams to develop team charters. How do we want to be together in the workplace? We make sure that leaders have the vision and they have the ability to articulate that vision clearly and to have somebody that can help them translate the vision into action. And you'll see the role definitions have to do with expectation. That's where most of the conflict lies in many teams. Ingredients of successful teams are all of these things. You'll see on there forgiveness and reconciliation. We shy away from conflict resolution. That's contract conversation. We work on forgiveness and reconciliation. That's relationship conversation. And it's those values and those processes that we're trying to embed into the teams that work in healthcare. The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. It's a challenge every day, whether it's in the corridors of the hospital, whether it's in ICU, or whether it's talking to a family about a donation. Yours is a tremendously challenging job. And as I started in terms of Peter's line yesterday, no task before relationship. The essence and the value of the work we do is about task, and they need to be integrated. And the biggest challenge has to do with evaluating, measuring, studying, doing the research around the relationship, because it may teach us that there's a whole wealth of information there that can actually help us with regard to the task. Thank you very much.
Thank you very much, David. Questions from the audience?
I'll ask a question, if I may, David, after heartily congratulating you for a magnificent talk. I think a lot of human existence is the denial of death, whether it's how we produce art, have children, you name it. What do you think it does to us, seeing 5 deaths a week times 30 years? Do you think there's any effect? Is it PTSD? Is it moral distress? Is it a bit from column A, column B, or?
I would say it's probably all of that and more. I think it begs the question of how is it I got to be in healthcare in the first place? Was it death that I was avoiding? And I have another slide called The Conspiracy of Silence, which is death and suffering and pain. And is it that why I go to the bedside in the first place? Is that why I chose to work in palliative care? I think that some would say that you don't live until you confront your mortality, so that it can actually distance ourselves from who we are authentically, and we could means that we may stay more dominantly or predominantly in our cognitive function rather than our emotional function. And some would also say that the longest journey is from the mind to the heart. And if we're afraid of what's in the heart, if we have the fear of death or the end of life, those might contribute to all of that, keep us distanced from each other. It's a great question, and it's a book. Denial of Death, actually. It's a well-written, it's a great book. Good question.
Thank you.
I think it's an important question we need to ask ourselves.
Thanks very much, David. Can I ask you, what is the opposite of vicarious trauma, moral distress, and compassionate fatigue? What is the positive parts of dealing with death on a daily basis that keep us from burning out and keep us from compromising our professional relationships and our family relationships?
A great question. Probably about 10 years ago, people asked that very question in terms of vicarious trauma, and out of that came the work that is now regarded as traumatic growth. And so that, I would certainly see it in the military, is to confront the demon, is to begin to ask the question, what is it that I did when I was overseas? What is it that I witnessed? What is it that I left there? What is it that I left in Canada before I went overseas? And it's the same questions we need to ask ourselves, that first of all, until it's me, it's not me. And I certainly learned that with regard to family members. And I was also part of the ethics committee at St. Paul's Hospital for a number of years. And people would often say, well, if this was your mother, what would you do? It's an understanding that the healthcare provider, unless it's your mother, it's not. So it's important to begin to differentiate some of those features and to also have an awareness that if this person reminds you of yourself in any way, to begin to address that and to ask those questions. So the opposite of all of that is self-awareness. The opposite of that is to acknowledge when you're being impacted by the work you do, and honestly saying it's beginning to drain me, it's beginning to affect me emotionally, and to say what do you need in the context of yourself, in the context of the people that love you, and in the context of your work team, to say that this work does affect me, and then how can we begin to work together to change that, to give you a break. But to also always ask the question, who am I? What do I want? And how is this affecting me? And despite the fear and the anxiety that might cause in terms of asking the question gets asked with the intent then of also looking for the answer. And the answer rarely comes overnight. It's like sitting in the woods. If you want to capture a wild animal, are you going to chase the wild animal, or are you wiser to sit next quietly to a tree and the wild animal might come to you? It's beginning to understand, one, that we are affected by the work, and two, that we can't always predict how it'll affect us. Three, the past is always present, so we can't bury it. It's with us, and it will affect who we are, our sense of self, and it will affect the relationships we're in, whether they're personal or professional. It's a beginning answer.
David, maybe one final question. We spoke a lot in the last session about building trust with the public and the families we work with. You alluded to that as well, as trust at a foundation, but you also mentioned a lot about organizational culture. We've got a bunch of leaders from the various OPOs in the room. I know I'm asking you to distill many years of work, but if they could invest in one thing in January 2017 for their organization, to build an organizational culture around this, what would you tell them to do?
Empathy. It's in the business world, it's everywhere, it's empathy. Empathy. I remember going to a meeting with a colleague of mine to see a VP of medicine, and she started crying in the meeting. And when we left the meeting, I said to her, "You must have been incredibly sad." She looked at me and she said, "What the hell, David?" I was furious. And I realized in that moment that she didn't need my interpretation of the tears, she needed empathy. So the empathy would have been, what is her experience, her behavior, or her feelings? So it would have been, I saw you express some emotion in that meeting, could you please explain what that was about? Right? So that whether you're the CEO or a senior leader is to begin to be empathic toward people and to begin to understand them from their perspective. Because in the work we did, there was often a big gap between leadership and frontline staff, and there's a misunderstanding in both directions. And so that if people could work hard to understand the context of the work. And I realize that I'm just beginning to understand the context of the work of all of you in the audience. It takes time, it takes questions, but more important, it takes listening, right? And to then also clarify, I want to make sure that I understand what it is your experience is. And if I'm not correct, could you please help me understand it? It's a process and it's a skill. And if it could start at the top, it would be more present at the bottom. It would change organizations.